Hello and welcome everyone to our webinar today. Very excited to present to you some helpful tips and things we've learned over the last year on assessing risk in healthcare. Obviously, it's a very broad topic and something that probably means a little something to each of you in your individual organizations. But the healthcare landscape has changed quite a bit in the last 16 months, which is a bit of an understatement. But we have been asked over the last year and a half to conduct several risk assessments, and working with clients, we get to see kind of what works, what doesn't, best practices. And so the premise of this webinar was to really share that information with a broader group. And so we have put together a presentation that I think you'll find helpful. And as Julia said, we've got Jay Swacker, who will speak on a part about developing the best risk approach. And we're honored to have Shawn Stevison join us today to give us a bit of an insider's perspective on managing risk within her organization. So with that, my name is Adam Shoemaker. I'm the Director of Healthcare Consulting Services at Dean Dorton. I've been with Dean Dorton for the past 12 years. Prior to that, I was at Ernst & Young. And really my professional experience is focused mostly on the revenue cycle, managing risk within the revenue cycle, improving cash acceleration opportunities, and reduction of bad debt, and all the key performance indicators around revenue cycle. I oversee our healthcare industry services team, as well as our consulting group, which focuses on risk assessments for practices, and our outsourced physician billing operation, which provides compliance and revenue cycle management services primarily for physician groups. So with that, Jay, why don't you do introduction, and then we'll let Shawn do the same.
Sure. Thank you, Adam. My name is Jay Swacker. As Adam mentioned, I'm a manager for the healthcare consulting team here at Dean Dorton. My background is in healthcare internal audit, compliance work. Prior to coming to Dean Dorton, I worked for about 5 years performing internal audit for a large multi-state, not-for-profit healthcare system, which is actually where I met our next speaker, who I'll turn it over to, who's Shawn Stevison. So Shawn, if you wanted to introduce yourself.
Thank you, Jay. So my name is Shawn Stevison. I am a CPA, over 22 years of experience, over 20 of which was working in healthcare. I have currently is the Director of Internal Audit at Signature Healthcare, but I have worked in healthcare for 20 years at Bright Spring Health Services, Jewish Hospital Healthcare Services, through all of their iterations, all the way up to Kentucky One Health, and now Signature Healthcare. I previously worked in public accounting for both Strickland & Company and also at Dean Dorton as an associate director in their healthcare consulting practice prior to coming into Signature Healthcare. I'm also certified in healthcare compliance through the Healthcare Compliance Association. I'm a certified healthcare internal audit professional from the Association of Healthcare Internal Auditors. I'm certified in risk management assurance from the Institute of Internal Auditors. And I am also a chartered global management accountant through the AICPA. And I'm also the incoming, or I guess now that we're in June, I am officially the president of the Institute of Internal Auditors for Louisville chapter. So I am delighted to be here and participate, and thank you for having me.
Thank you, Shawn. Looking forward to your part of the presentation. So the agenda is now pulled up. Well, this is what we were hoping to cover in the hour that we have together is let's talk a little bit about assessing risk, kind of what has changed within the last year and a half. What are some of the emerging risks that have emerged out of COVID, some of which you may be all too familiar with, and there may be some surprises that you'll hear from us that can give you some information to go back to your own organizations to see if there are threats or risks within your companies. We'll share a little bit about developing your risk assessment approach, what works, what doesn't work, and how to modify your approach. And then Shawn's going to give us an industry perspective unique to her role, what she's seen within her company, what others are doing across the healthcare industry, and just a relevant perspective that hopefully we get some takeaways to go back to our own organizations. And we've got some questions that we will share with Shawn to get her feedback. Just real quickly on Dean Dorton, if you're not familiar with Dean Dorton, we are a CPA and advisory services firm. hard to believe, going back almost 100 years now. And we've grown quite a bit, especially in the last 5 to 10 years. We've opened up a much larger office here in Louisville. We have a physician outsource billing and credentialing office also in Louisville. And we have opened a Raleigh, North Carolina office. So we've grown quite a bit in the last 5 to 10 years. Healthcare is our largest industry team that we serve. It's probably 25% of our firm's revenue, and we're working with healthcare clients throughout the region and nationally. Very proud of the work we've done in sort of gaining notoriety amongst what we're doing in the healthcare industry. We've been recognized as the best place to work for a number of years now. So if you're not familiar with Dean Dorton, we have grown quite a bit, and look forward to presenting to you today. So risk advisory services, that's one of the sort of the main services that we offer. And the consulting world, most every angle of those services have a compliance risk. So whether it's managing your practice or managing a department within your hospital, there's certainly the financial and operational considerations that we help clients with, but they all have a compliance angle. And how you manage the risk, whether it be regulatory or compliance, is very important. And so hopefully today you'll get some helpful pointers on how to assess risk within your organization. But in terms of other services we provide, outsourced medical billing and credentialing, technology, accounting and financial services, and human resources, all have very practical appeals to clients, but also have a compliance and risk angle that we'll touch on. When you think about managing risk within your organizations, there have been some very sort of historical key risks that most organizations have focused on, and rightfully so. Everything on the screen now is a legitimate concern, a legitimate risk to every healthcare entity. So whether we're talking about billing compliance and making sure that your providers are documenting and billing appropriately, whether we're talking about personnel turnover and training and educating your workforce so that they know what to do and when to do and where to go if they have questions or concerns, all of these are very legitimate risks and ones that we've grown very accustomed to managing. I mean, each of these items on the slide currently are almost always on a compliance internal audit work plan of some sort. And so these are risks that we're all very familiar with. But one of the things we want to do now is say, how do you best integrate these new and emerging risks with the ones that have always been out there and still continue to monitor these and make sure that you're preventing them at the highest level. Why now? The reason that we've decided to do this webinar now is because, one, we've been asked over the last year and a half to do several risk assessments. All for varying reasons, but primarily it's because organizations have been so overwhelmed with COVID-19 that they want to make sure they get an outsider's perspective, or at least a sort of a guiding hand on, are we doing what we need to do? We're stretched thin, margins have been decreased, staffing has been a legitimate concern, and so many organizations want comfort in saying, where are we missing? What are we not doing well? Where do we need to get additional support? And I won't go through all of these sort of new risks now, if you will, but a couple that come to mind. The increased use of telehealth over the last year has been a phenomenon that has grown in almost every healthcare organization. And either there was not a telehealth presence within many organizations and they had to scramble to do one very quickly, or it dramatically increased the volume, the bandwidth, the users. And so if you're not looking at the risks around telehealth, whether it's the security or the accuracy of the coding and billing of it, you should probably start to incorporate that into your compliance management process. That's one that has impacted pretty much every healthcare entity. Another one that a little different angle on sort of managing risk is it's not always what your what is actively threatening you, but sometimes it's what you stop doing or what you're just not doing as well as you used to. And an example of that is what we're calling the absence of innovation. And it's, I think we've learned over the last, 12, 15 months, many organizations were doing very well at gathering feedback from their employees. And employees would proactively say, hey, I'm not sure why we're doing this, but it's costing us money here, or it's a duplication of efforts. But there was sort of this natural innovation, if you will, within companies where employees felt free to say, hey, we could do this differently or maybe save money if we tried this way. We're seeing now clients are actually losing a little bit of that because the presence of people working from home, they're a little more disconnected. They don't know their employees and their colleagues as well, so they're maybe a little more not as likely to suggest good ideas. So sometimes the risk is also just about what stopped and then how do you get that back. And in the absence of innovation was one example of that. The third one I'll touch on is revenue cycle in a virtual environment. Nearly every revenue cycle department over the last 14, 15 months has had to go to a much more increased level of virtual involvement, whether that's hiring staff from around the country or just sending everybody home and bringing them back. Managing revenue cycle performance and the compliance is much different today than it was pre-COVID. And so trying to figure out how you incorporate that into your risk plans is integral, because I think there's going to be some level of telecommuting that is here to stay. The employees like it for the most part. And so we're going to have to figure out as an industry how to manage performance in a virtual environment, which is very different than what we were doing a year and a half ago. Here's 3 examples of risks that clients have came to us and said, we did not realize this, but COVID sort of helped to expose risks that we weren't really fully aware of. And the 3 things we've heard are, we didn't know that XYZ person or department did not have a backup. So the level of cross-training was exposed, the level of sort of, training within a department or a singular person having the full authority to do certain tasks. And when that person was out or ill or unable to work, there were exposures around sort of that process and not having the appropriate training or transition plan to make sure when someone was out that critical tasks were still completed accurately and timely. That was a current theme. Another one was just internal IT bandwidth. So not only were they trying to stand up a telehealth solution, they were also trying to get a significant portion of the employees to work remotely. And many of these IT teams did not have the bandwidth, or it fell on such few people that they were really working long, hard hours, and the morale was quite poor, all while trying to make sure that the telehealth service was up and running, that it was compliant, that it was generating revenue, and that patients were satisfied with the visit. So that was a very key risk that sort of came out of the last year or so of many of our conversations. And then the third thing was just really was related to when the volumes dried up, and then they came back on slowly last summer, June, July, August, the capacity to then handle that volume wasn't there. Whether it was because of furlough or internal transitions or resignations, when the volumes came back, many of our clients did not have the team then in place to support it. And sort of another hidden risk associated with that was if you had outsourced parts of your service, neither did your outsourced vendor. They were dealing with some of the same struggles as the employers, whether it was a hospital or a physician clinic. If your early out vendor was all working remotely all of a sudden and they had people out, now statements weren't going out. And so there were very significant consequences of bringing back rev cycle functions online when the volumes came back and trying to keep up. So just sharing those as 3 things that came up. You can, look at your own organization to see if any of those hit you or not, but we wanted to share with what other hospitals and physician groups were struggling with. And Jay, now I'm going to hand it over to you for to walk us through the risk assessment objectives.
Thank you, Adam. So when we work with our clients, either as their outsourced internal auditor, or perhaps we are have a co-sourcing arrangement to perform internal audit functions, one of the first things that we do is perform a risk assessment. And really, we want to walk out of that with three key things. One, the first thing we want to do is identify, risks posed to the organization's strategic plan from a global perspective. And I think that's something that global perspective has taken on added significance in the past year. The next slide will kind of look at our healthcare risk universe that we typically used and the lens that we looked through performing those engagements prior to the pandemic. I briefly discussed, maybe coming out of it, what are some things that we would add to that universe? Once we have gathered information and talked to folks within that organization to identify the risks, the next step is identifying resources and expertise needed to address the most critical ones. And once we have an understanding of those risks and the resources to mitigate them, then it's really working hand in hand with the client to develop concrete plans to address those identified risks. So on this slide, really is our kind of healthcare risk universe that we have typically thought of. They fall under 6 kind of main domains of financial risks, regulatory compliance risks that I'm sure we're all familiar with, reputational risks. Obviously, in the past, you never wanted to have any sort of incidents occur at your healthcare facility that might land you on the front page of the newspaper or have a story run on you on WKYT. You wanted to provide care and present yourself to the community as, a very competent, caring organization that's really working hard to do the right thing and care for patients at a very high level. Technology, revenue cycle, I think all of those things remain. But you'll notice under the enterprise level risks on this little pinwheel that we have, some of the bullet points down here, we just have a bullet point for economy. And I think in the past year has forced us to look at that at a broader, at a much, put more attention in that area. I think the pandemic has changed, not just the economics of how various healthcare organizations within different sectors within healthcare operate, but now we're into a whole new ball game in terms of, as we hopefully come out of the pandemic and, moving forward, COVID-19 is not quite the acute crisis that it is now. I think certain healthcare leaders need to be very cognizant of things such as, what are the vaccination rates in the communities that we serve? If they lag behind, may we be at risk for another surge of COVID-19 cases in the fall? And if that is the case, what do we need to prepare if that contingency comes to bear? And then I think a lot of the other kind of structural changes that we've seen, moving forward, we'll get into those discussions, I think, a little bit more with Shawn. But obviously, this was kind of the universe that we're looking at now. Are these items, but much more focused on overall economic, population health, epidemiological considerations are in play now as well. As far as conducting a risk assessment, when we come in, some of the first things that we do is that we want to identify collaborators within the organization that we will be working with, throughout these engagements. Typically that would be their senior leadership, folks on their compliance or internal audit functions, things like that. Those would be the main folks that we would be working with it. But, there may be other, obviously other folks that, they're external auditors who are doing some piece of the pie in terms of identifying risks and managing them. From that step, we really want to gather information both internally generated from the organization and external to it. We want to survey their workforce to really get a feel for, what kind of risks and concerns do folks that are on the front lines of those organizations, what acutely are they feeling? Then our next step would be interviewing leadership and having really productive conversations. You know, once we have had a chance to kind of gather and digest this information and the feedback from the workforce, review, really review and pull out, what are the key risks that we face as an organization. And then that last step is really acting on those results. And I think certainly through the course of the pandemic, I think it's just accelerating that change within, kind of the internal audit framework of that, risk assessment is not really a once a year thing or a one time a year thing. It's really something that if you are managing an internal audit department, it's something that you need to be thinking out about, throughout the year and how that might be changing, what new risks may be appearing that once we did, a lot of these formal steps, maybe we only do them once a year, how might they change? So with all of that being said, now we'd like to bring in, as we mentioned, we have a third speaker on the call today, Ms. Shawn Stevison, who has a wealth of experience on all these items, and we will kind of go through, I think, each of the steps and some of the new risks that we've seen. So with that, I think we can kind of hit on some of these, 4 new emerging risks, maybe discuss them in a little bit greater detail. Adam, I know you kind of had a question for Shawn about how, maybe her organizations, other organizations that she's aware of have handled the remote work transition.
Well, I know it's something that a lot of organizations have struggled with, Shawn, and so I guess, just what is your sense of how well companies are managing risk with a remote workforce? How has that changed over the last, year or so? And what do they need to be aware of?
Thanks, Adam. I'm happy to address that. I will say that when I give you my perspective, I'm giving it to you from a more global perspective. I'm drawing on information that I have from my experiences with other organizations, as well as from being involved with the IIA and the HCCA. So keep that in mind. I'm not just speaking from my own personal experience here. But most organizations I'm aware of made a very rapid transition from in-person, in an office setting to a remote setting, people working from their homes. Some of them didn't have softwares and systems in place, didn't have the technology at home to be able to work, no monitors, no cameras, no microphone systems if they needed it, maybe not even headsets or what have you. And IT departments were very, very stressed in making that transition. There was a very quick rollout of technology in a lot of cases. Many of those technology rollouts did not have the typical internal audit, IT processes and procedures that are in place for software development lifecycle and change management documentation, and those things that allow you to track what you did, when you did it, and how you did it, and how those security controls are in place to protect your PHI, PII, and your company's confidential information. And so a lot of organizations did that very quick rollout, got their folks working remote, and then went, oh my gosh, we don't know what we don't know because we moved so quickly, and spent a lot of time then going back and saying, okay, let's go back in and let's really look and see, did we set up the technology with the right controls in place? Do we have them on the right server systems? Do we have them on the right bandwidth? Are we transmitting the information securely? And is it being returned securely? And is it encrypted during transmission? Those things that we know logically should be in place, but don't always get I's dotted and T's crossed in a heat of a moment when you're going from, we're in the office working on Monday, and on Friday, everybody go home, right? So there's a lot of work done kind of after the fact by many, many organizations, IT departments, and internal audit functions to try and go back and do those double checks and triple checks and do detailed dives into anything that was rolled out within that time frame in response to that remote workforce shift. So if you have not done so already, that would be one area as you're looking at your risks and you're looking at what next steps should be that I would definitely focus in on is, did we set up that technology the right way? Do we have those security settings the way we need to have, especially in the healthcare environment for PHI, PII auspices, make sure that we're set up the way we need to be. So that would be one of those big things to think about. In terms of go forward, some organizations are moving their folks back in-house. They're opening their offices slowly. There's transition plans to bring folks in town and back into their offices. There are other organizations that have made decisions to take entire departments and maintain them remotely. Some of those things that we are seeing that are tending to be more remote are those things where they can manage your productivity based upon volume. So in a healthcare setting, revenue cycle. A lot of organizations are leaving their revenue cycle remote because they can monitor the volume of bills that are going out. They can monitor the collection volumes that are happening, the calls that are happening, things of that nature. But is that an effective and an efficient measure of productivity? You have to evaluate that. You have to look at what metrics you're utilizing. What is the source of those metrics? How are you reviewing those? How are you using those to manage those individuals within those departments? And that's just kind of an obvious location. Other departments that I know organizations have discussed going remote on, that it's a little bit more of a tricky situation from my mind is IT. There are some organizations whose IT departments are remaining remote for those that don't have to be physically within a server room doing monitoring of the server system. Their help desks are going remote. They have some of their key infrastructure individuals that are staying remote. That becomes another issue. Again, I'm kind of teetering back here towards IT a little bit in that regard, but they're staying remote. And then some organizations have said, nope, we want everybody physically present. We want them there. We want to be able to see them. We want to be able to manage them and organize them and be able to have that in-person interaction. I would say managing the workforce is more challenging in a remote environment because you don't have that familiarity and that kind of relationship where you can walk down the hall and have a conversation with person A. And person A says something, and you're like, oh, I need to go talk to person C. So I can walk downstairs, I can talk to person C. You have to make a conscious effort to maintain your environment and those relationships through setting up scheduled calls with those individuals to touch base and just see how things are going. And you have to make the effort to reach out in a way that is not necessarily just specific to a project or a risk assessment, but in the manner of, I'm just touching base to see how things are going in your area. What's going well? Where are you running into challenges? That water cooler talk that you don't get if you're not physically present next to someone. Does that make sense?
Oh, absolutely. And I think kind of related to some of the things that you're touching on with, particularly the technological and compliance challenges of, the rapid transition to remote workforce, equally applicable to telehealth. I think the other wrinkle with telehealth, really in addition to that, that is worth continuing monitoring was there was a really broad mishmash of guidance from individual payers on what types of services they would cover under telehealth, what documentation they required. Now that we are kind of coming out of the, really more severe stages of the pandemic, what of those temporary changes will payers adopt moving forward? I think probably the most critical payer to monitor there obviously would be Medicare. Prior to the pandemic, I think, Shawn, you and I could spend hours and hours talking about the very, very detailed requirements that Medicare had in place for telehealth, both the technology itself, where the the telehealth visit, where that patient was actually physically located, where the distant site provider was located, which of those changes are going to remain in place. I mean, it seems both from the Trump and Biden administration during this, they are looking at a lens of, we want to adopt a lot of these temporary changes. We see this as very beneficial to Medicare beneficiaries moving forward. What exactly that shape takes, how that all takes shape is something that we will certainly be monitoring moving forward. I think another...
You're absolutely correct in that regard. When you're looking at the telehealth component of it, they made some of those telehealth codes permanent with the 2021 PPS. And they've got others that they emergency certified that they're now doing information gathering on in 2021 that they're looking at potentially making permanent as well. I don't think we're going to see rehab become permanent. I would be shocked if that's the case. It's just not as, I don't think it's as effective when you're not in person. But there's a lot of other telehealth codes that I would anticipate, based upon the information I've seen come out of CMS, that they'll be looking to make a viable telehealth option going forward.
Mm-hmm. Let's transition for a moment, Shawn. I know another area that you know quite a bit about, and I think something that anybody that is in healthcare would would have been impacted of in the past year is, you know, the receipt of provider relief funds. You know, I think both one kind of what is the timing moving forward in terms of, you know, will there be any more provider relief funds released? But then also, if you're an organization that you know received a certain amount of PRF funds, you may now be subject to a single audit, which is something that you were not previously subject to, which I know is your role, you know, with the IAA and HCCA, something that you have looked at extensively.
I have actually. The provider relief funds provide an interesting situation for everyone. They said that we were going to have to start reporting back in June. The portal wasn't live. They've now just this past week issued new guidance on the reporting timeframes for the provider relief funds that have been previously received, as well as done a slight extension on certain of those for the use of those funds. We're still, you know, waiting to see what the portal is going to look like when it opens up and what that format has to be. But what I would say from an organizational perspective is make sure you understand what all you received in provider relief funds. Because not only did you receive monies directly from the federal government through your deposits based upon your revenue and whatnot, whether it was the general distributions or it was directed, targeted distributions, you're going to need to know what the amount was of each of those types. But then think about any funds that you receive from states, any contracts you signed with states. If you're an organization that signed a contract with the state to be a COVID site, or to accept transfers from organizations that were unable to host COVID patients, that money that you received from the state for doing that was pass-through funds. They're going to be subrecipient funds that you received that were through the provider relief funds or the coronavirus relief funds. Those that came through the state pass-throughs are coronavirus relief funds. A lot of healthcare organizations got them, and if you don't read very, very carefully through those contracts, you might miss it. So make sure you're identifying those funds, and that you've identified your provider relief funds, and that you have some type of a process in place to account for all of the expenditures related to each of those types. You're going to have to break it down into windows. They've got specific dates out there now, which, because it's so new, I don't have them memorized yet. I have to pull up that little document that just came out. So it's out there. I'm happy to give that to Jay and Adam, and they can get it out to all of you if you'd like it. But realize that if you cross that $750,000 threshold and you're a nonprofit organization, you're subject to single audit. That's a 133 for those old people like me that are around back when it was referred to that. Single audit, federal government, government auditing standards, governmental accounting standards for those funds. Different from what we go through on a normal day-to-day basis. Those organizations out there that have been involved in clinical research and have received research funds, you're going to be more familiar with this. And it should be fairly simple for you to just add it to your schedule of expenditures of federal awards, your CFA. Those of you that have never been through it before, it's going to be a very detailed audit. They're going to look at your accounting controls. They're going to look at your other internal controls. They're going to be looking at compliance aspects related to each of those funds. Things that were spelled out at the beginning, and all of those things are added on at the end. And if you're an organization that receives donated goods, so donated PPE, you have to estimate and report the value of that donated PPE as part of those filings. If you haven't already done so and you didn't track it at the beginning of who it came from, what the volume of those donated items were, now is a really good time to get started on gathering that information because you're going to need it.
Certainly.
And just for the benefit of the group, Jay and Shawn, we've put together quite a bit of information on that whole topic. So, and actually a whole separate sort of task force within the firm helping clients manage that, up to date with the latest developments with the portal and reporting. So if anybody has questions or concerns about that piece, feel free to reach out to us and we can connect on that directly.
Absolutely. I could talk for several hours on the PPP loans and the provider relief fund, so I'm just going to leave it there. If you don't have an internal task force already looking at this information, I highly recommend you getting a group together of your cost reporting folks, your accounting folks, your internal audit folks if you have them. I would even recommend pulling in your revenue cycle folks and anybody who handles anything related to your inventory, specifically as it related to COVID supplies, COVID testing, COVID expenses. Start having those conversations now.
Sure. Thank you, Shawn. I think the other kind of emerging risk item that we have on here is I think going back to what I mentioned earlier about really broadening our lens in terms of what kind of risks or changes in the the landscape within healthcare organizations operates is really the kind of the patient service mix changes that were brought on by the pandemic and kind of the reverberations that are still being felt. I mean, obviously, as anyone on this call, I'm sure is aware, at least in the state of Kentucky, we had elective procedures shut down for a period of time, by mandate. And then, but beyond that, I mean, many folks were reticent to even, go see a provider in person or have maybe normal screenings, routine care, things like that done in person, during the past year while there was a pandemic. So, obviously, those decreases in those caseloads of surgeries led to decreased volumes of patients, non-COVID patients in hospitals. And then, that led to decreased referrals to skilled nursing or home health, those sort of things. As those volumes are slowly going back up, we're seeing those, those kind of work their way through the system. But we're also seeing, maybe higher acuity patients coming into the system that, in the past, those patients would have been seen sooner. We're also seeing, I think, as we've discussed before, we're seeing, I think, some probably permanent changes in patient behavior. We're seeing decreases in ER visits. I think those will remain the case moving forward. We're seeing a huge uptick in telehealth utilization, and I think those will be, as we've discussed, will be moving forward. Shawn, do you want to speak to, maybe very broadly, what kind of what should organizations be monitoring in that regard, and how it might impact their kind of strategic plans moving forward?
Certainly. When you're looking at these types of changes, you saw it happen kind of abruptly. And Kentucky was by no means the only state in which those elective procedures were shut down. That was fairly consistent across those population centers where they had a high volume of COVID cases. You saw that shut down because the hospitals really didn't have the beds for it. And they were struggling to handle the COVID patients. Kentucky, our hospitals were not quite in that boat, but that decision was made and that call was made. The impact overall from an organizational perspective when you're looking at strategic plan, your strategic plan is built off of what you've budgeted for, right? So your budgets are built based upon expected census levels and volumes of patient procedures and volumes in the ER, et cetera. So what has happened is those impacts resulted in the inability to have that revenue available to respond to those items that were on your strategic plan. But then because of the pandemic, you saw things that were nowhere on anyone's strategic plan become the highest priority because we had to respond to the needs that we had at that moment, right? The shift to the remote workforce, the need to invest in telehealth to be able to provide services. So when you're doing your risk assessment and you're looking at the coming year, I would first take a step back and say, well, what was our strategic plan and what were our strategic goals for 2020 pre-COVID? And how many of those things did we really achieve? And then as you look at 2021, same thing happens, right? We go through our budgeting process, we set what our priorities are, we set our estimates for our revenue, our expected expenditures, and then from there, we're able to determine what volume do we have available to move strategically. Well, we're still not quite all the way back. We're getting there, right, nationally. But we're also starting to see the emergence of some of these other variants, like the Delta variant that is starting to show up, at least in Louisville, most recently, where they're more infectious is what they're saying, and they're also seeing a higher level of acuity in the Delta variant. So how is that going to, as we look for the last half of 2021 and we look into 2022, what is that going to mean to what we had strategically determined to do in 2021, and how is that going to impact our ability to respond in 2022? So when I think about patient and service mix changes, I'm thinking about what was our strategic plan, what did we not achieve because we had to shift focus, how did that impact our organization from a risk perspective? Because how many of those strategic items were designed to mitigate or address a risk that had been previously identified? And how much of that strategic plan was something that was a newer and emerging technology that was an investment we were going to make for future? And what does that do to that future roadmap for that service line, that product, whatever that item was? What does that do? And how far out does that then push that timeline? And then does that make that item irrelevant in our new environment post-pandemic? And that's a question that every organization should be taking that step back and saying, okay, was what we thought was our strategic objective pre-pandemic, is that still a relevant strategic item, or is it changed dramatically as a result of the pandemic and our responses there too? So that's where I would go when I'm thinking about those emerging risks as it relates to patient and service mix changes, budget, anticipated impacts as we see things change, vaccination levels, emergence of new variants, and the things that are going to have an impact on us as we continue through 2021 and look into 2022.
Thank you, Shawn. So we've got about 15 minutes left. We may want to run through a few more of these slides fairly quickly. I mean, I think we kind of touched on identifying key collaborators. The only thing I would say that really I feel like would maybe change in this area due to the pandemic is really how we communicate with folks. So much in the past would have been, face-to-face meetings, things like that. Or if you're doing work, you're doing it, somewhere physically where you're close to folks, where, maybe we had a meeting and we talked about something, and then after the fact, I had a question or a thought, I could go kind of more easily, naturally, follow up on that. But I think a lot of the things, the considerations, like you said, how have management's goals, concerns, how is their view on their strategic plan that they had prior to the pandemic changed, and then what will it look like moving forward? As far as internal sources of information, I mean, I think obviously we've touched on quite a few times in the talk, really starting with the strategic plan, your organization's mission, vision, and values, really having that be, kind of the driving force for your risk assessment. How, like you said, I think now is really a good time to kind of do take a step back and see, okay, well, this is what we were planning to do. That got ripped to shreds in 2020, but I think it will provide a lot of clarification in terms of, what do we really need to focus on moving forward, or what were we missing, before that? And I think, Shawn, to your point, we can discuss a little bit about, like a organizational departmental KPIs. I think it's coming from a compliance, risk assessment, internal audit focus. What do other departments, areas within our healthcare organizations, what were they focusing on pre-pandemic? How has that changed? How are they measuring that information? And what are they what kind of reviews are they doing internally now coming out of it?
Well, I think it's interesting. That's an interesting question. I don't really see a lot of KPIs changing. What we were monitoring for from a pre-pandemic perspective are still a lot of the same things we're monitoring post-pandemic, right? Revenue cycle metrics are revenue cycle metrics, right? Your accounting metrics are your accounting metrics. Your compliance metrics didn't really change. What it did is it added significantly to the workload of those individuals in compliance, in the revenue cycle, in operations, with the expectations and the data that had to be gathered, monitored, reported, and then disseminated. You had key infection control items that had to be tracked and logged and monitored and reported, and you had to do that in a very organized way to make sure that you're reporting the right information to the right health department, to the CDC, to whomever else you need to report those statistics to. That puts loads on compliance to make sure we're compliantly gathering it, to the individuals that are submitting it, that's submitted appropriately and timely, and to those frontline individuals that are gathering the data to gather in the appropriate manner. So I think that those are new departmental KPIs that we would have in place, but in general, we're not seeing anything change. All the same things still exist. We're just seeing added on levels of KPIs that were not maybe monitored prior to, specifically around infection control and those requirements for the reporting as a result of the pandemic.
I mean, I think, obviously there's been a tremendous focus on infection prevention, but I think some of the things that with some of the clients that we've worked with, how clinical education and competency was assessed, prior to the pandemic. Some of those things almost kind of had to be paused, in terms of a lot of like in-person competency assessments, verifications in nursing units, things like that. As we're coming out of it, what's our plan to kind of get that education and those competency assessments back in place for areas that maybe relate to patient care but are not, strictly infection prevention focused? In terms of our measures of, patient safety, patient quality, do we see any significant changes or, deterioration on some of those measures, maybe, or for, workforce safety, while we were really focused on infection prevention and having PPE for our staff, during coronavirus cases surges, were we seeing increases in back injuries with our nursing staff because, maybe they didn't have the appropriate equipment to safely move, patients, things like that, areas where they don't directly relate to, treating COVID patients, preventing our staff from contracting COVID while caring for them, but other areas where, we could have seen employer patient harm, as a result of the stresses that were put, on our clinical operations during that time period.
I'm certain there are organizations that experienced that situation where some things became secondary to dealing with pandemic-related situations. But for the most part, industry-wide, those measures don't go away because they're certification measures, right? They're survey measures. So allowing them to fall completely by the wayside, I have not experienced with the organizations that I've interacted with where they have let them fall completely to the wayside. It's still out there. There was still a push to get the education out there. There was still that push to monitor and track all of that information. And from an infection control perspective, there was no flu this past year, or the flu that was out there was minimal because of masks, right? So there's some metrics that, were monitored and reported on that are showing up very differently. And so as we think about risk assessment going forward into 2022, we need to take a step back and we need to look at the data that we've gathered on all of those KPIs and say, okay, are any of these data points going to be what I would call outliers, those things that in a normal operating environment where we don't have state mandates or CDC mandates that say we have to be in this type of a mask at all times, or whatever the case may be, do these data points change? And is the reason why we have a, 1,000% change in a statistic of something that we were doing because of the pandemic? And so what is the reality of that? Did that risk really go away? No, it didn't. But we've got to take a step back and say, okay, that was the current state then. What's going to be our current state in 2022 or the rest of 2021, depending on when your year end is and when you do your risk assessment? And how is that going to impact what that number is going to look like as we move forward? So do we need to take into account that, yes, this looks like it's a very low risk item, but these factors contributed to it being low risk this past year. Take these factors away, what does that number look like differently? And how do we need to respond and address that risk in the coming year? So that's where I would focus my energy on with those KPIs and the clinical quality and those safety measures. And even, looking at your workers' compensation data from a, employment perspective, what are those KPIs indicate in terms of changes that are direct results of changes in operations because of COVID? So you're not going to have a good year-to-year comparison necessarily looking at pre-2020 and then looking at 2021 and as these environments and our operating environments change. So that's where I would say don't just rely on the numbers. Take into account those other factors that go into those numbers.
Sure. Let's see, we've got just a few more minutes. I think, as far as external information, we've got a few resources here. Shawn, I don't know if there's anything additional that you would add. A lot of these are very much focused on, regulatory compliance, in terms of monitoring that information. Anything else that you would add that maybe you're looking at or you would recommend folks look at now in addition to this?
Yes, I would say look at the activities from your MACs, your RACs, your UPICs. Look at the activities on additional documentation requests that you're receiving in. If you're receiving a ton of ADRs from a specific payer, or you're receiving a ton of ADRs from Medicare or Medicaid, there's usually a reason for that. That means they're looking at something specifically. Figure out what that pattern is and factor that into your risk assessment, because those are great indicators of what it is they're looking at. As MAC, RAC activity, obviously, but those ADRs can be an early indicator of something that maybe the MACs and RACs are thinking about. So they've asked for ADRs to go out so they can take a look at those and look for indicators of issues where they can maybe dig in and have large recoveries. So look for those. Those are good indicators as well from an external perspective.
Sure. We've got just a couple minutes left. As far as, surveying your workforce, I think, obviously at this point, I think you're going to have to use some sort of online tool like SurveyMonkey, something to reach folks that are working remotely, things like that. Obviously, I think updating the questions that you're asking to include, really wanting to solicit that feedback. What changes, what challenges, what concerns did you have that were, brought on by the pandemic and how things were handled, and obviously, transitioning to a more remote working environment. What feedback can we get from folks there? I think that's really, two of the areas that I would really want to make sure that we reach out and get feedback from their frontline workers to kind of keep an understanding, because that's really where, you may have, really critically examined your strategic plan and things like that, but how is it really being implemented on the ground, or how has it been impacted on the ground, I should say?
I think a survey is a good tool. I personally like a more personal touch. I think you can only get so much out of a survey, and you can't read tone and you can't read body language. So what I do with any surveys that I send out, I get that information in, I evaluate it, and then I will key in on areas where I'm going to go and do more in-person interviews with folks and read the body language, read the tone of voice, understand where they're coming from, because surveys, if you catch a person on a bad day, they're going to get a very different answer than if you catch them on a good day. That's facts of life. It doesn't matter who you are. It doesn't matter, what area you operate in. The response is going to differ day to day. So take all of it with a grain of salt. Don't rely on it as chapter and verse and no change can be made. Take it with the lens that, okay, this is a good starting point, but then go out and talk to the folks that are in those areas. Use that information to gather more specific, relevant, feedback that will allow you to aggregate that data in a way and put a value to it and put a risk level to it that is pertinent and not just solely based on data points.
Sure.
Shawn, I've also found that in-person interviews are much more effective than these virtual interviews. People tend to open up more and speak more freely, and you just connect with them better.
Mm-hmm.
So how do you protect those interviews so that you still get the information you need while also just building confidence in them and that it's a confidential process and you're protecting, what they're sharing?
Well, understand that risk assessment is by its nature confidential. And you have to set that tone right from the very beginning of this information is confidential. However, I want you to understand that if there's an issue that is disclosed to me during the course of this interview, that I may need to escalate it and that I will do my very best to keep you out of it, but I want you to understand that, certain things are out of my control. And be open and honest with individuals. When you're real with them, they're going to be real with you. And I have never once had somebody not tell me something, knowing that I've told them up front, there's that potential. I'm going to do my very best to keep everything you tell me confidential and use it to aggregate data so that I can figure out what we need to look at. But if you tell me something that's a high compliance risk that we need to address immediately, I'm going to tell somebody, and I'm going to make sure that they know about it. And if I can avoid bringing you into it, I will. But if they need to talk to you, I need you to understand I may have to give them your name so that they can talk to you. And again, it's being open, honest, opening that line of communication, building that trust and rapport. And that comes with time. Each time you talk to them, each time you have conversations with them, you're going to build that trust and that rapport a little bit more. And that's why back when we were talking at the beginning, I said it was so key to schedule those times to reach out to those individuals that are key to your organization and that are key to departments and areas, and have that 15, 20-minute little chat. Catch up with them, what's going on in their lives, what's going on in their departments, what challenges are they seeing, what's going well, and have that. Because when you get your risk assessment, our risk assessment is going to be a lot more open and honest than it is if the only time they see you is one time a year.
Agreed. Yep, completely agree. And Jay, we're kind of up against the clock here. I want people to be able to ask a question if there are any. I'm not sure if Julia has seen any, but if there are, we could address those now.
We have not gotten any questions, but like everyone says, we encourage them, and we would love to hear from you.
And if you don't mind, I have one more thing I wanted to just throw out there. When you're looking at items you gather during your risk assessment, there are going to be some things that you just can't get to in your audit year. It doesn't matter how many staff you have in-house, or if you outsource projects, you're just not going to get to it. So it's really key to sit down and say, is this something that the department can monitor on its own and report data back to me, so that if the data looks skewed, then we can maybe say it's a higher risk and do something with it. So it's really important to have those conversations, talk to those departments, and give them that opportunity and that option to do some monitoring on your behalf. It's not an internal audit. It's not something that you're going to necessarily be able to solely rely on because, again, it's subjective to who's doing the review. But it's a way to keep an eye on something that needs to be looked at and the bandwidth doesn't exist. But you have to keep in mind departmental priorities and their resource constraints as well. So as you're looking at that, make sure that that's factored in as well.
Certainly, certainly. All great points, Shawn. And I guess I know we're right at time. Again, I just wanted to say thank you. It's as always, a pleasure to talk to you. You know, I think this is definitely a subject that you and I have had discussions on for, you know, close to a decade at this point. So it's always something that I think, particularly at this time, is worth revisiting. You know, how we're approaching, you know, these kind of internal audit, you know, risk assessment, risk management activities. You know, now that we are hopefully kind of coming out of the pandemic, you know, we're looking forward, and you know, we're certainly operating in a much different landscape than we were 16 months ago. Adam, did you have any other closing thoughts?
I just wanted to echo that, Jay. Shawn, thank you for joining us. Always good to be with you. Thanks to those who joined us today. And really, the key takeaways are risk management it's never done. The risks are evolving. They're changing daily. They're changing with the economy, with the landscape. And so you've got to pick and choose where you have resources to address the ones that are the biggest threat to your organization. And it's not a one-size-fits-all, and every risk approach is different for each organization. So hopefully this was helpful. I enjoyed it. Always good to hear from Shawn, and appreciate everyone joining us today.